Okay, this is my trauma patient assessment. Okay, so first I'm going to make sure I'm wearing my appropriate PPE and that my scene is safe. Once I've established that, I'm going to do my scene size up. So I'm noting that I have one patient. I'm noting that the mechanism of injury was a fall from a ladder. I'm going to request for ALS backup, and I'm going to instruct my partner to maintain inline C-spine stabilization. After completing my scene size up, I'm going to approach the patient. My general impression is I have an unresponsive patient lying supine on the ground. Their chief complaint is trauma following fall from a ladder, and then I'm going to assess their level of consciousness. Sir, can you hear me? My patient isn't responding to verbal stimuli, so I'm going to apply painful stimulus. My patient is groaning, so I'm determining that their level of consciousness is alert to painful stimuli. After this, I'm going to begin my ABC assessment. First, I'm going to open the airway. I'm going to assess for any secretions or injuries that are preventing adequate ventilation. I don't know any. At this point, I'm also going to size and select the appropriate sized OPA and insert it into my patient. Next, I'm going to assess their breathing. I'm noting that they are breathing shallowly at a rate of 1 breath every 6 seconds. I am noting that they are not adequately ventilating, so I'm going to request that my partner begins ventilating the patient at a rate of 1 breath every 5 to 6 seconds. And I do not note any injuries that are preventing adequate ventilation that can be corrected at this time. After this, I'm going to assess their circulation. First, I'm going to feel for pulses. I feel pulses in both the carotid and radial arteries. I'm going to assess their skin. It appears pale, feels diaphoretic and cool. I'm now going to initiate shock management. So I'm going to connect oxygen to my BVM at a rate of 15 liters per minute. I'm going to keep my patient supine and thermoregulate my patient. At this time, I'm going to consider this patient a high transport priority based upon their apparent GCS. Following this, I'm going to go into my secondary assessment with a rapid trauma assessment. I'm going to start at the head. I'm going to palpate and inspect the skull, feeling for any deformity or injury. I'm going to look in the eyes, ears, nose, and mouth for any signs of bleeding or secretions. I'm going to feel on the face for any signs of injury or deformity. And I'm going to assess pupillary response. Okay. I'm then going to move down to the neck. I'm noting or looking for any signs of tracheal deviation or jugular venous distension. I'm also going to palpate the C-spine, feeling for any signs of deformity and looking for bleeding. Following my neck assessment, I'm going to move down to the chest. I'm going to palpate the clavicles, sternum, and the ribs. At this time, I'm going to feel if there is adequate bilateral chest rise following each breath that my partner administers. I'm noting equal and bilateral chest rise. I'm going to auscultate the chest in all 4 fields. I note that there are clear breath sounds in all 4 fields. I'm then going to visualize and palpate the abdomen. I'm feeling for any tenderness, rigidity, or guarding. I don't notice any deformity or injury. I'm then going to assess the stability of the pelvis. The pelvis appears to be stable with no injury. I'm then going to move, at this time, I do not believe it's clinically relevant to expose or examine the genitals. Following that, I'm going to work on the upper left arm. I'm palpating down, assessing for any injuries or deformities. I'm going to assess the pulse, motor, and sensory function of the extremity. I'm going to repeat the same on the other extremity. I'm noting a deformity in the midshaft femur. I'm going to stop palpating and then begin palpating from the bottom up to the site of the deformity. I'm going to assess the pulse, motor, and sensory function of the extremity. I'm then going to palpate the upper arm, moving down, feeling for any injuries or deformities. I'm going to feel for a pulse and check for circulation and motor function. And I'm going to feel down the other leg. I'm noting another femur fracture, mid-shaft, closed. I'm going to stop palpating and move up from the bottom until the point of injury. I'm then going to assess pulse, motor, and sensory in the distal extremity. Okay. I'm now going to, on the heads count, log roll my patient to assess the posterior lumbar and thoracic spine, the flanks, and the buttocks for any signs of injury or deformation. I'm not noting any. I'm going to then, on heads count, log roll my patient back onto a backboard. Okay. At this time, I'm going to get a baseline set of vitals. During my primary assessment, I did not note any major hemorrhage. Okay, baseline set of vitals, I'm going to get a blood pressure, an SpO2, a respiratory rate, a heart rate, and I'm going to listen to breath sounds. Breath sounds are still clear in all four fields, and I'm also going to assess pupillary response. I'm going to attempt to obtain a sample history from any bystanders on scene, as the patient is unresponsive and unable to provide that information. I'm then going to reassess my patient every 5 minutes. I'm going to continue to transport them rapidly as a high priority patient to a trauma center. I'm going to notify the receiving hospital that we are coming in with a trauma and provide them with our estimated time of arrival. I'm also going to manage the secondary injuries of bilateral femur fractures by splinting. I'm going to assess pulse, motor, and sensory functions in both extremities prior to and following application of the splint.